Today we're going to dive into allergic rhinitis, also known as hay fever. This is the most common type of respiratory allergy, and it affects millions of people every year. In the United States, about 20 million adults live with allergic rhinitis. It's a type I hypersensitivity reaction, which means it's IgE-mediated. Early diagnosis and treatment are important, not only for symptom relief, but also for preventing complications like sinus infections or worsening asthma. Let's start with the causes and seasonal patterns. Allergic rhinitis is usually triggered by airborne allergens like pollen or mold. Tree pollen is common in the early spring, grass pollen in the early summer, and weed pollen, especially ragweed, in the early fall. Mold spores thrive in warm, damp weather. In places where temperatures never reach freezing, allergens like mold can persist all year. Now, what's happening inside the body? The pathophysiology starts when allergens are inhaled. IgE antibodies are produced and attached to mast cells and basophils in the respiratory system. When these cells are activated, they release histamine, which is the main chemical responsible for nasal symptoms. The result is inflammation, edema, vasodilation, and all those hallmark symptoms of allergy. A key finding is eosinophilia, an increase in eosinophils in the nasal and respiratory mucosa. Speaking of symptoms, let's talk about the clinical manifestations. Patients often report sneezing, runny nose, nasal itching, and congestion. They may also have red, watery eyes, postnasal drip, coughing, or fatigue. On exam, you might see dark circles under the eyes called allergic shiners, or a horizontal nasal crease from constant rubbing, the so-called allergic salute. The nasal mucosa can look pale or gray, and there may be fluid in the middle ear. Some patients even develop oral allergy syndrome, with itching in the mouth or throat. And for many, allergic rhinitis is linked with other conditions like sinusitis, eczema, or asthma. Diagnosis is usually based on history and physical exam. Laboratory tests are not always necessary, but skin prick testing can identify specific allergens. Blood IgE testing is another option, though it's less common. Sometimes nasal cytology is performed, but it's not very specific or sensitive. Now let's move into management. The goals are to relieve symptoms, prevent complications, and improve quality of life. Treatment generally includes avoidance strategies, medications, and for some patients, immunotherapy. Avoidance therapy means reducing contact with allergens. Patients can use air conditioners, HEPA filters, mattress covers, and dust-proof pillowcases. Removing carpets and heavy drapes can help. Pets may need to stay out of the bedroom, and clothing should be changed after spending time outdoors. Showering before bed can wash off pollen, and saline nasal rinses are simple but effective. When avoidance isn't enough, we turn to pharmacologic therapy. Antihistamines are the first category. First-generation antihistamines like diphenhydramine and chlorpheniramine are effective but very sedating. They also have anticholinergic effects: dry mouth, urinary retention, blurred vision, which makes them especially risky in older adults. Because of that, their use is limited today. Second-generation antihistamines like loratadine, cetirizine, and fexofenadine cause much less drowsiness and are generally preferred. Some patients may benefit from combining H1 and H2 blockers, for example, adding famotidine if symptoms aren't fully controlled. Antihistamines can also be combined with decongestants, though patients with hypertension or heart disease need to be cautious. Corticosteroid nasal sprays are considered the most effective pharmacologic therapy for allergic rhinitis. Medications like fluticasone, mometasone, and budesonide reduce inflammation directly in the nasal passages. These sprays need to be used consistently, often daily, and the full benefit may take 1 to 2 weeks. Side effects are usually mild, like nasal dryness or burning. Adrenergic agents, or decongestants, like pseudoephedrine and oxymetazoline, can temporarily relieve nasal congestion by constricting blood vessels, but they aren't recommended for long-term use. Oral forms can raise blood pressure and cause palpitations or tremors, while nasal sprays can lead to rebound congestion, known as rhinitis medicamentosa, if used longer than 3 to 5 days. Mast cell stabilizers, such as cromolyn sodium, are another option. They work by preventing mast cells from releasing histamine. These sprays are used prophylactically and must be started before exposure to allergens. They're safe, but they need frequent dosing, and it can take a week or more to notice benefit. Leukotriene receptor antagonists, like montelukast and zafirlukast, block inflammatory mediators called leukotrienes. They're taken orally and can help with both asthma and allergic rhinitis. However, montelukast has been associated with neuropsychiatric side effects like anxiety or depression, so it must be prescribed with caution. Finally, we have allergen immunotherapy, also called allergy shots or allergy tablets. This therapy involves gradually introducing allergen extracts until the body becomes less reactive. It's effective for many patients with pollen, dust mite, or pet dander allergies. Immunotherapy can reduce symptoms, lower the need for medications, and even change the course of disease over several years. But it carries a small risk of systemic reactions, including anaphylaxis, so it must be administered in a monitored setting. Now let's focus on the nursing process. In assessment, patients often describe sneezing fits, watery nasal discharge, itchy eyes and nose, and headaches. The nurse gathers a detailed history, including family allergy history, seasonal patterns, and medication use. The nurse also observes for hoarseness, wheezing, hives, or rash. Nursing diagnoses for allergic rhinitis include impaired breathing, lack of knowledge about allergy management, and difficulty coping with a chronic condition. Potential complications are anaphylaxis, impaired breathing, and non-adherence to treatment. Planning and goals are centered on restoring normal breathing, improving knowledge, promoting coping skills, and preventing complications. Nursing interventions include teaching patients how to minimize allergen exposure, promoting adherence to medications, and clarifying the difference between rescue medications, like antihistamines, and maintenance therapies, like nasal corticosteroids or leukotriene modifiers. Nurses also help patients cope with the year-round inconvenience of allergies by providing emotional support and encouraging stress reduction strategies. Monitoring is essential. Nurses watch for signs of anaphylaxis or respiratory distress and ensure that emergency equipment and medications are available. Education about auto-injectable epinephrine may also be necessary for those at higher risk. For home and community-based care, nurses provide patient education about environmental controls, correct use of medications, and adherence to immunotherapy schedules. Patients must understand the importance of waiting at least 30 minutes after immunotherapy injections in case of systemic reactions. They also need to know the risks of medication overuse, such as rebound congestion from decongestant sprays. Finally, in evaluation, expected outcomes include clear lung sounds, normal respiratory patterns, improved knowledge about allergy management, adaptation to lifestyle changes, and absence of complications. Patients should be able to identify allergens, describe avoidance strategies, explain their medications, and demonstrate how to self-administer emergency treatments if necessary. To sum up, allergic rhinitis is common, but very manageable with proper education, avoidance measures, medications, and in some cases, immunotherapy. Nurses play a critical role in assessment, teaching, and supporting patients as they adapt to the challenges of living with chronic allergies. That concludes today's lecture on allergic rhinitis.